Thank you. All right. Big sigh when it comes to this project, I have to say. The amount of work involved in this was essentially a 10-year project, and I'm going to present some lessons that we learnt in getting this off the ground and hopefully provide some assistance with other people who are looking into doing this. And when I was preparing the slides for this, I thought of John Hines and his quote, and I think it's particularly relevant to this kind of thing, or this kind of innovation, that really if you're going to do it properly or don't do it at all. Having said that, I am very cognizant of how ECMO and ECPR may be construed in some quarters, and I think those concerns should be listened to. So what I thought I'd do is, before I get on to some of the lessons that we've learned in Sydney from our pre-hospital trial, I'll spend a minute on the iterative development of innovations in healthcare. Here on the left you see a chap with gloves and a NASA head-mounted display with a data glove interface. This is Dr. Scott Fisher. This was a theoretical controller for telerobotic systems. And then beside him is Colonel Anthony Laporta, who was operating an early version of the telepresence surgeon's workstation. And this is really the progenitor of telerobotic surgery. And you can see from seed funding in 1988 and a little bit of a mock-up, you end up with transatlantic surgery being performed in 2001. So things do develop over time. And if you look at the evolution of TAVI, this Danish doctor's idea came in 1988, and by 2019 there was 75,000 TAVI procedures per annum being done in the US. And in some ways ECMO has come along on a similar journey, from the first heart-lung bypass in 1953 to the first pre-hospital ECMO CPR in 2011-2012 in Paris. And the technology of ECMO itself and the portability of it has also improved, from a big machine and lots of tubes to the Ironman type 2.0 you see here in Dimitri Yiannopoulos' team, where they're trying to make it easier and more portable. I think, though, what's key in any innovation or technology like this is a strong foundation. And core to that is a high-performance culture. There are lots of organizations that follow this kind of curve of performance who are average or mediocre, or some who are utter amateur. And on the far right side, you do have some highly professional organizations. And I think you need something like this before you embark on doing something as innovative as ECMO CPR. I would advise everyone to read this book if they haven't read it. This is The Culture Code by Daniel Coyle. And he talked about culture, and he said, culture is a set of relationships working towards a shared goal, not something you are, but something you do. And that really resonated with me. And that relationship is not just within your own organization. You need to develop a scaffold of relationships with multiple organizations and stakeholders. Doing operations research, which I'll come on to, is key. And then you need motivated drivers. And those drivers are, what do the patients need in your population? Do they need ECMO CPR? Are they out there? And then you also need individuals to drive it. You need people to drive it. It won't just happen. So this is a bit of our operations research over the years to get to the point of ECMO. We started looking at our ECMO retrieval program, which started just before the H1N1 pandemic. And then we looked at how we did the ECMO movements. Then we did look back on ECMO CPR in Sydney. And then we looked at a feasibility in-hospital trial called 2-CHEER. And then we moved forward to look at, okay, we seem to be able to do ECMO CPR in the hospitals. What does that cost? We looked at cost effectiveness. And then we looked at the patient population in our registries. Do we have the patients that meet criteria for ECMO? Where are they? Whereabouts geographically are they, and do they exist? And then we did the evidence cardiac arrest trial, which I talked about yesterday. And then we moved forward looking at, well, what would the survival benefits be based on time to ECMO? And we produced some literature around that. And we did some interesting traffic modelling with Emily Moylan and Sydney University. And if you look at these small little dots, these are the ECMO-capable hospitals. The big kind of peach area is the Greater Sydney area. And the peach colour is the conventional cardiac arrest survival, which is 10%. The blue is ECMO CPR reach from those hospitals. And the darker the blue, the higher the survival. But on the left side of the screen, what you see there is estimated survival of about 17% for ECMO CPR in those catchments around those hospitals. So a very small footprint. That supplies about 800,000 of the population. What if you were to send mobile teams out of those 5 sites, as you see on the right, then you increase the reach to about 2 million, 2.2 million, and the survival comes up a little bit to about 22%. This is modelling, so it's just based on our registry data. If you put an optimally placed car somewhere in Sydney and then have a single mobile unit moving around, this is the reach you get in the greens. This is the ECMO CPR reach, and then survival. The darker the green, the higher the survival. Obviously, the darker the green is closer to the car. It's all time-based. But this gets us to about 3.8 million people. So we did that research, and then we developed a training program that Natalie Cruitt developed for us within the Air Medical Service. It was very iterative. It developed over time. It started from a blank canvas. And I think the education was very multimodal. It was based on the GSA-HEMS induction program style. So it was pre-learning, VLE, and then iterative simulations and building up. And then we had key elements of focus, and the focus was ECMO criteria, cannulation training, so skills in cannulation, running onto the pump, and then the first 4 hours. That's it. Not looking after them in the ICU, just the first 4 hours. That's a QR for Nat's paper around the learning and how we achieved it. But suffice to say, the training was very in-depth. It was well thought out, a lot of theory, and then face-to-face classes. Then we had ultrasound training. A lot of us do ultrasound already, but actually we learnt a lot in IVC imaging and also in groin and femoral anatomy imaging. And then moving on into PIG labs and cannulation, workflow cannulation training, ECMO training, circuit, priming the pump, initializing pump emergencies, and then we started getting into the workflow. Then this is a competency assessment was then based on ultrasound. Can you recognize the anatomy? Can you confirm your sheath and wire? Visualize the IVC with the wire? Do basic transthoracic echo? And then perform the cannulation. And then go on to initializing the pump and looking after the pump. And that was only the start of the beginning, I would say. So this was actually taken on one of the first days where we got the paramedics in to look through the workflow, and we kind of said, okay, New South Wales Ambulance, the rest paramedics, advanced life support team are above the Lucas, and the ECMO ALS team is below the Lucas. And then we started doing our usual way of workflow and assessing how we are doing. You can see Natalie there, she's assessing paramedic with perfusion, and there's a doctor cannulating. We started inside, and then we started moving it outside. Okay, how would we do this outside? What are the threats to doing it outside? You can see the cannulas the circuit is very well secured. We started looking about how do we move them, how do we get them off the ground. And you can see bit by bit things are starting to build up in terms of the flow, the equipment. We've got some very smart people in the room watching and giving some feedback. And this was, again, like I said, iterative. And you can see we're now starting to control exactly how we do it. We do it the same way every time. But very like other air medical services work, have packs down the end, have a clear workspace, monitors always in one place, ECMO pump always in the same place, and the ultrasound machine always in the same place. It's a 2-doctor cannulation team and a critical care paramedic looking after perfusion and also integrating with the ALS team. We have task cards for all aspects of what we do, and that's often used in the hospital as well in terms of running onto ECMO. Again, just some more footage of us doing the training, and then we had a part task trainer as well. And perfusion was a big thing for us, so we had a lot of help from perfusionists in training the actual perfusion aspect of ECMO. These are our go, no-go criteria that we use on the scene. So we look at the selection, inclusion criteria, which is witness arrest, immediate effective bystander CPR, VF, VT, or PA with signs of life, and consider frailty. And so if they don't meet the criteria, you stop. And then you go further down, you go, okay, can you see the femoral artery with your ultrasound? If you can't, you don't proceed. There's no fishing around in the groin with the needle hoping you're in the right place. So you stop if you can't do that. And then we go on to the next phase of having put the sheaths in and the wires up. We confirm one wire is in the IVC and the arterial wire can't be seen. So we're, at that point, confident that the wires are in the right place. And then we progress to the cannulation. A big thing in Sydney HEMS is emergency action cards for big ticket items like hypoxia or hypercapnia or shock. And we copied that with respect to ECMO in terms of, we expect people to remember these things, but under cognitive stress, you may not remember. So we have action cards around access insufficiency, afterload, pump failure, and some of the big key items. This is just an example of the kind of workshopping that goes on in those simulations and training that you saw, people literally writing things on the whiteboard, and then usually one of us would take a photo of that and start working in these iterative developments. It didn't stop with the training. We also applied the aeromedical idea of currency training, like you do in airways, and we try and maintain currencies by going into vascular labs, into cardiothoracic theatres, and getting cannulation or vascular access training. And then we also set up a part-task trainer within our responding base to do workflow simulations and training. So it's not good enough just to train the team to be high performance, but you actually have to train the whole system as well. And the pre-hospital system was very important, and it needed to be geared up and prepared for. And in that model, and because of that, we did a lot of cross-training with the paramedics and the rest of the ambulance service very early on. We brought them in, we took their feedback about how we can integrate with the ALS team that's already at the arrest. They're not handing over to us, we're all part of the same team. We appointed a paramedic educator from the critical care paramedic group in aeromedical to help with the education of paramedics in the workforce. And then we appointed a clinician to sit in the control center in a desk and look for cases and actively look for cases. And I think a key to the success of trying to do something like this is trying to get to these patients extremely quickly and early on to buy time. The hospital system also required a lot of work in terms of process alignment. For this trial, we bring patients to 3 hospitals. We generally would do a pre-notification. If we're going to put someone on ECMO, we get a call sent through to the hospital to say there's a case going on ECMO so that they're aware. And then also there's a formal notification as well. There's, in terms of the guideline development, we had to do a lot of work around neuroprognostication and post-resuscitation care. Took a lot of discussion to finally reach consensus, but again, very key to successful outcomes in ECMO CPR, having agreed consensus and processes in place. Site updates are pretty regular, and we did a case review board for each case for the first 10 cases. So literally investigators from each hospital, the aeromedical service, and externals from nationally within Australia and internationally, we would get together and review cases. And actually we got a lot of learning out of that by sharing information and talking to one another. And actually that was quite potent, I thought. So eventually we did launch in August 2023, and we have been going since then. And I'm going to run through some learnings that we've had from them. And in terms of the ECPR cases, they're going to split it into non-technical and some technical learnings that we've had. What we found by going to the scene of the arrest, be it in someone's home or in the sports field, what we assume in the hospital when paramedics bring patients in and say this was witnessed or unwitnessed, it's not that straightforward, and it's sometimes grey. Sometimes the information changes when you're there. And when we do an ECMO cannulation, we do have a pause point, time out, so to speak, for about 5-10 seconds when the wires are up to confirm the criteria for a second time. But sometimes someone might say, I didn't see the person for 10 minutes. Versus I heard them drop in the room next door, which will be witnessed. This 0-point survey that Simon Carley and others have worked on, I think, is critical to creating the chance of success in this in terms of your self-team environment, patient update and plan. I routinely will use this when we're trying to do this. The self-mastery, cognitive skills are so key in this. And in one of the cannulations, I look back at my watch and my heart rate had gone to 133 at one point, and I realized I had to bring that down. The team is everything, integrating with the ALS paramedic team that are there, but also we have a hands-off external team leader, paramedic team leaders, usually a senior paramedic who's engaging with what's going on, but also getting other rescue agencies in to help as needed. So we do actually get fire involved a bit in terms of lighting when it's dark or providing shade when it's too sunny. Environment is everything, as everyone knows in the pre-hospital setting. So we're trying to force the environment to suit our needs. So 360-degree access, getting stuff out of the way, and ensuring that we can get proper access to the patient. And then one of the key things we started doing is ensuring that the patients are getting really good ALS and really good effective CPR, because you could get to the patient, look at the CPR going, proceed to cannulation, but the CPR may not have been effective. So that's a key kind of pause point when we get to these patients. And the update as you're going along is key. So the 2 ECMO doctors and the paramedic within the ECMO ALS team are constantly communicating, but also there's communication with the ALS team that comes through our critical care paramedic. And in some ways, the critical care paramedic has the most onerous task in that they're assisting us with and looking after the pump, setting the pump up, handing out the circuit, but also interacting with the paramedics who are on the scene. To reiterate, you definitely need to do your operations research first. When you do good background, review and research into why you're making the case for ECMO CPR, it's very hard to argue with it. Or if you look at cost effectiveness, hard to argue. Engaging all the stakeholders from the beginning and getting buy-in is everything. Engaging experts both locally, nationally and internationally was very important to us, and we got everyone who does ECMO CPR on calls multiple times, and they gave of their time for free, and we really appreciated it. And you also need to engage administrators. You do need to talk to the bureaucrats. In the end, this costs money. So the government, politicians, you name it, they're all involved. I think designing a bespoke training program with core competencies and processes is key. And I think nailing down the post-resuscitation care or guideline in advance is very important. And again, to reiterate, ensuring the hospitals are maximally invested in the success of the trial or the program is crucial. Otherwise, it won't succeed. Case recognition is crucial, and having a paramedic clinician in the control center looking out for cases is so beneficial, because often cases come through as a seizure or a collapse rather than a cardiac arrest. The ongoing education and training of the paramedic workforce, it was core to all of this. And there was a lot of really good feedback that came back from the hot debriefs that we would do. So we bring the patient into the hospital, and then once they were handed over, we would have a hot debrief with the paramedics on the scene, and we would take their feedback, and that was done in a very formulaic way. The other key thing is to maintain momentum after the patient's on ECMO. There's a big adrenaline dump that happens, and then they're on ECMO and there's a big sigh, but actually that's where the fun and games really begin, and the patients need to move off the scene. So we actually created a pre-departure checklist for that to make sure, we've secured the lines, we've got an art line in, we're aiming for a map target, we're doing an EFAS to make sure there's no intra-abdominal trauma, we're checking the cannula, the venous cannula position, and maintaining that momentum to try and move, because they do need the problem that caused the arrest to be fixed. 360-degree access and environmental control is crucial. In terms of technical aspects, with the arterial puncture, which is the gateway to ECMO CPR. From my own personal experience, what I found was helpful is bringing the needle down and trampolining on the top of the vessel. Once I got to that point, we'd briefly pause the Lucas device, get the needle and the wire in, and restart the Lucas. So you get a pause of 5-10 seconds, and sometimes we found if you bring the angle of approach down steep onto the vessel and then puncture the vessel and then bring the angle down so you can feed the wire. After ECMO was established, we would generally go to a right radial art line, preferable to femoral, and closed loop communication with positive confirmation I found very helpful. So if I was ECMO 2, the assistant to ECMO 1, I think it's really helpful to say, yes, I can see the common femoral artery come down. Yes, I can see where the SFA and the profunda split come back up. And that positive reinforcement is very helpful, because it's quite a stressful thing to do. And then verbalizing the anatomy is something I do personally. So I will, as we're getting down and exposing the patient, I'll go, there's a symphysis pubis, there's the SIS, that's the inguinal ligament coming down. I'm identifying the vessels. I think avoiding over and under ventilation, both pre-ECMO, CPR and on ECMO, is crucial. Decompressing the stomach is a big thing that we focused on early on. If they've got an over distended stomach from BVM, you often get difficulties with ventilation, you got preload issues, and then for a subxiphoid echo to look at the venous cannula, it can be quite hard to see what you're looking at. Securing the lines is paramount. If you end up doing all the work and getting someone ECMO and then an arterial cannula backs out, that's a game changer. It's over. A predefined process for securing the machine and the vent and the ultrasound and transport was key. And then building in redundancy. So we do actually carry a spare, smaller ultrasound machine, because if the ultrasound machine breaks or freezes, which has happened, again, you can't get to the vessels, and some redundancy in the equipment as well. High performance CPR is not guaranteed in any system, I don't think, and repetitive training and practice is needed, because actual exposure to cardiac arrest is relatively infrequent among clinicians in hospital, but also in pre-hospital. And we do focus on the entire chain of survival. There are some critics out there who say you're just doing ECMO CPR because you're interested in ECMO. We're not. We're very interested in early bystander CPR, early defibrillation, and hopefully getting ROSC before any of this is needed. Oxygenation, I think, is underemphasized in the guidelines and needs to be looked at. We're definitely seeing patients who are asphyxiated and don't have enough oxygen going around. And like I presented yesterday, adrenaline is often given late in cardiac arrest. In terms of the non-ECMO CPR cases, we started going to a lot of cardiac arrests that weren't ECMO eligible, and we started really studying those as well. And effectiveness of CPR is very variable. You know, the anatomical location of the heart is variable in patients, but also depending on the ventilation and stomach, all those things. End-tidal CO2, we think, is not necessarily a reliable perfusion marker during CPR, and there's a lot of reasons for that. There's asphyxia, like I mentioned. The duration no flow time will contribute to a higher CO2. And if the right ventricle is just being compressed rather than the left ventricle, you're just going to get pulmonary blood flow and high CO2s. And then some patients appear well perfused during arrest and some don't. And it just seems to be the case. Minimizing, so why do some ECMO CPR cases do better than others? Well, I think minimizing the no flow time is crucial. Ensuring the low flow time is short and the CPR is effective. And I can't emphasize that enough, that the CPR needs to be effective. Vital organ perfusion and oxygenation is everything. And I wonder, does the cause of the arrest play a part? You know, do patients with coronary occlusions do better than patients with arrhythmias and cardiomyopathy? I'm not sure. And perhaps some patients have a genetic predisposition to tolerating low flow state or hypoxia more than others. So in terms of effectiveness of CPR, I think the area of maximal compression obviously needs to be over the left ventricle, and at the moment we are using TOE with Nat Cruitt to look at that. But more research is really needed into surrogate markers of effective CPR. Is that an art line? Is it a pleth trace? Is it end-tidal CO2 with the caveats I mentioned? Is it a pulse check? Or is it signs of life with CPRIC? I'm not sure. There's a lot of talk about physiological guided resuscitation. The AHA is pretty vague on targets for this, but we do need to have some targets. I do think we need to head towards that direction. And how do we monitor perfusion? Because we've talked a lot about blood pressure, but perfusion and flow is everything. And should we be using NIRS like they use in cardiothoracic theatres? It's very hard to do pre-hospital. It can be done, and the Dutch are using it. Do we use TOE? Or do we use invasive blood pressure, or do we use a combination of them all? And then in terms of augmenting the circulatory support, a lot of work going on head-up CPR, you know, the active compression decompression devices, impedance threshold devices, and then ECMO. This is a video just to show good, this is TOE showing good RV and LV compression, so you can see really good compression during cardiac arrest there. And then when you see the monitor, you get a really good dichrotic notch, and you're seeing like what looks like a normal arterial line trace. And actually, during the course of the arrest, this patient's oxygen saturation level just kept coming up. And this is 20, 30 minutes into the arrest, and the sats just keep coming up because the patient has got forward flow, the heart's ejecting, there's good CPR. Similarly here, you can see, you know, good compression going on. And what we do at some point is then, you know, check. We've got an art line in, so we're going to pause at some point and see, is the heart doing anything? It seems to be standstill. And then you see the art line just kind of disappears and you see the pressure dropping. So we recommend CPR. So my last reflection is really a personal one, and to plan, prepare, and deliver an innovation such as prehospital ECMO CPR does come at a personal cost in terms of time and energy, which often means less time spent with your family or doing something else that you want to do. So I would say that it's something you really need to think about if you're going to embark on something like this. This is not just a cool intervention. Some patients do need it, but it is a lot of work, and it does come with a penalty from that perspective. So you have to be aware of that. And that's it. Thank you.